everyone, in today's video we're going to be talking about wound care. By the end of this video we'll be able to demonstrate how to complete a wet to dry dressing, how to assess a wound, and how to successfully remove staples and sutures. So the first thing to know about wound care is that before any dressing is complete, we need to assess the wound itself. And the first things to look at when assessing a wound are the wound's location and the wound's size. In my first illustration up top, I've added a massive pressure ulcer to the coccyx of this patient. It's important to remember that pressure ulcers are most likely to occur in areas of bony processes, and that means an area where the bone predominantly sticks out toward the skin. So that could look like the elbow, the heel, the bottom, the knees, areas like that. And what follows is assessing the wound's size. We are responsible for being able to accurately measure a wound by its imperial measurements, i.e. inches or centimeters, as well as being able to communicate its size relative to a commonly known object. This pressure ulcer would be the size of several quarters, but if we were measuring it accurately, we would want to take a measuring tool and measure it from the widest part and the longest part to give a general area of the size of the wound. Following location and size, we want to be able to look at wound drainage and wound tunneling or undermining. Undermining and tunneling are most common in stage 3 and 4. They're actually the cardinal signs of stage 3 and 4 pressure ulcers. Stage 4 would include tunneling or undermining all the way down to bone. That's always going to be your cardinal sign of a stage 4 wound. But you need to be able to measure the size of the tunneling and undermining too. So you would want to take a long and skinny cotton swab, we'll use this marker for an example, and you'd want to take it into the wound itself until you reach the deepest part of that wound and assess how deep your cotton swab went based on your accurate measuring tool. If you find any tunneling as well, you're going to want to take your tool and follow that tunneling to its deepest point so you can measure that accurately as well, so that you can communicate these findings to the primary care provider, the attending, whatever. Drainage is what you're going to be seeing as you're changing the wound itself. It's going to reflect as a dried liquid on the bandage, whatever you're using. And I've created what's called the Serous to Sanguineous spectrum to give you a better idea in your head of how to identify the drainage. Serous drainage is identified and characterized by mildly clear fluid. And the further we get to the sanguineous side of the spectrum, the more the liquid is viscous and red. Sanguineous drainage can be the result of hemorrhage, and that's important to remember. But in this middle part, we have what is known as serous sanguineous drainage, and that's when you start to see that red coloring. You start to see the blood come out of the wound. So serous is clear, and the further you get to sanguineous, the redder your drainage gets. One thing I also want to mention is that there is purulent drainage, and that can be the result of infection. Purulent is basically pus coming out of the wound, characterized by an aromatic, thick yellow substance. So now I'm going to demonstrate how to properly change a wet to dry dressing using the skills and information we just went over. So we come up to the patient and we see that they have a bandage on already, so we need to change this one out. We're going to remove the bandage with dry, clean gloves on, and we see, oh goodness, this patient has some red in it. We can pretend that this was some sanguineous drainage that we found, so it will be important to keep that in mind and report that. We'll dispose of the old bandage properly, and then we will get our own kit and begin preparing to change out the dressing. The first thing to do is going to be setting our sterile field using that inch border we have, and I will lay that over here. The rules of sterility are going to be assumed for the purposes of demonstration because I don't have a lot of space to work with. My recommendation next would be donning the sterile gloves, just because it'll be easier to take the rest of your equipment out and use it. So I don't think these will fit. We're just going to pretend I'm now wearing sterile gloves. So we have our measuring tool that we can use in a second to measure that wound. tape for putting the bandage on, gauze for saturating the wound, a biohazard bag to remove and to dispose of anything as necessary, scissors to cut off the previous bandage if needed, and our normal saline solution. So now that we have all of this assembled, first I'm going to go ahead and take my measuring tool, and my suggestion would to be use something that is a little less flimsy, but if you can see, we have an inches ruler at the top right here, so we can take our wound and measure it at its widest part to be at about 3-ish inches, and then the longest part to be about 4-ish inches. So next is to dress the wound ourselves. We're going to take our normal saline solution, and the recommendation is to pour a little bit of it into our kit here. We will take one of our sterile hands and dedicate that to dipping the gauze, dampening it, not saturating it, and packing the wound. So we would start with taking a gauze, getting it in a little bit of saline, and we want to fill all of the excess space in the wound. And my suggestion would be taking another tool like the cotton tip that we could use to measure the tunneling, which reminds me, that is something else we need to do. So we would take a thin tool and we would go into the wound to assess for depth and tunneling. So this can be our packing tool. We will continue to dampen with our one non-sterile hand and pack. I think we can get one more in there. We'll dampen and we will pack. And once we are packed in, you can use both hands. And then our last part of the job will be taking a new fresh bandage, putting it over the wound, taping it appropriately, and then writing the date and the time the wound was attached. The dressing was attached. For the final part of this video, we're going to be discussing how to safely remove sutures and staples. I don't know the rationale for why a surgeon would choose to use one or another to close an incision, but it is important to understand how to safely remove either when preparing further wound care. To first address sutures, it is important to note two things. One, that sutures are removed every other. So if we were to start on this side, you would remove the first one here, and then the one after it here, and then the one after it, and so on. The reason for this is that if you just remove them in the order that they're sutured, what is left would not be able to hold that incision together, and you could risk evisceration and further damage. In addition to removing the sutures, you're going to want to be cleaning the wound as you go. So best practice is to start from the most contaminated and go towards the least contaminated part of the wound. Incisions, like any other wounds, are not completely sealed, so they are at risk for developing infection, which is why we clean them. Staples, on the other hand, are a little bit simpler. If you've gotten to use the tool in lab, it looks like a pair of tweezers with 3 prongs. You're going to use the 2 underneath and then the 1 up top. So the idea is you go underneath the staple with the 2 prongs, and as you begin to close the tweezers from the top, it will push the middle of that staple downward and pull the outsides up to make sort of a shape that looks like that, like an M. And it will open up the staple and you can safely lift it out of the skin. The same rationale applies, that you want to go removing these staples from the most contaminated towards the least contaminated, and it is just generally safer to be removing them one after the other. One thing I do want to mention is that the tools for removing a suture involve tweezers that are used to hold the string in place, and then you clip them with a pair of scissors and just pull it right up. It's a lot less complex, but still important to know. Thank you for watching. Let me know if there's anything you think I missed. I would be more than happy to re-record any section that needs additional redoing. and good luck on your next exam.